Hello students. Today I'll talk on a topic called shock. Shock is a very important topic to understand, and accordingly if you have a good understanding how your body reacts to shock, you can accordingly manage the patient well. So my talk on shock will have following subheadings, as in first we'll define what is shock when you call it as a shock, then what are various types of shock, various classification of shocks, what is the pathophysiology, how does the body respond to the shock state, and what are the various clinical features patient will manifest in a case of shock, and the investigation needed if the patient is in shock, what investigation you advise, and finally the treatment of the shock, various shock we are dealing. So the first comes the definition. What is the definition of the shock? Definition of shock is it's a systemic state of low tissue perfusion. In this, the tissue is uh, having a low tissue perfusion. The perfusion is inadequate for a normal cellular respiration of the tissue or the cell. So it's a systemic state of low tissue perfusion because of the low oxygen supply or low nutrient supply through the blood. The received blood supply is inadequate to sustain the normal cellular function which it has the purpose. How do you define shock? If the BP is less than 90 systolic and less than 60 diastolic, then you call it as a patient is in shock. Next parameter is something called as MAP, that is mean arterial pressure. If it is less than 65 mm of Hg, then you call it as a shock. Mean arterial pressure is basically the diastolic pressure plus one third of the pulse pressure. Pulse pressure is the difference between the systolic and the diastolic BP. So diastolic pressure plus the one third of the pulse pressure is equals to mean arterial pressure. Now, if the body is in the state of shock, how does your body respond to the state of shock? There are defensive mechanism of your body in order to overcome or to prevent the organ, to prevent the vital organ to prevent the what you call tissue death. So first is the normal aerobic respiration of the cellular respiration is converted or shifted to anaerobic medium because there is less of blood supply, so there is less of oxygen supply and nutrients, so body has to take over some other mechanism so that it can survive for a longer time. Second is, as there is less blood supply in the body, it tries to shunt the blood from the less important organ like muscle, GI, skin and limbs to the more important organs like brain, heart and kidneys. How does it do? By the brain stimulating the sympathetic system. So what happens? There is some sympathetic stimulation which leads to diversion of blood from less important organ like in muscle, GI, etc. to the more important brain, heart and your kidneys. Now what is aerobic respiration and what is anaerobic respiration? So when you have adequate amount of blood supply, you have adequate amount of O2. So the respiration in the cell will use the O2, and finally the end product that is excreted by the cell is the CO2 that get mixed or dissolved into your bloodstream, and through the bloodstream it reaches the lung, and from lung it is excreted outside. Whereas in case there is decreased blood supply, there is decreased amount of oxygen in the body or decreased amount of oxygen that reaches the cell. So what happens is there is no oxygen, so body changes to alternate mechanism to give energy to the cell. So it will generate, in that event it will generate lactic acid, that is lactate, and this lactate is further released or dissolves into your bloodstream, and it will call lactic acidosis in this patient. Next is shunt mechanism. So when your baroreceptors in the carotid pulse senses ki you are having a low BP or patient is in shock, it sends signal to your brain that the patient's BP is low, kindly do something. So your brain sends signal to the less important organ. One of the less important organ is the skin through the sympathetic stimulation. This is the stimulation via your hypothalamus to the skin tissue. It gives a nerve supply to the skin. So normally what happens, you have an arterial blood that goes to the skin, and through the skin it dissipates some sort of heat, and it makes the skin warm, and then it traverses back to the venous system and into the veins. But what happens when there is low BP? It is stimulated, your sympathetic stimulation is there. So what happens, it gives stimulation to the arteriole, and the arteriole there is vasoconstriction, so no more blood is going towards the skin. Plus it dilates the shunt vessel. This is the shunt vessels. It is dilated with the stimulation of the sympathetic stimulus. So this becomes dilated, so the entire blood is diverted from the arterial system, not passing through the skin but through the shunt vessel back into your systemic circulation. So this limb is no more warm because the less blood supply is there. There is severe vasoconstriction. So this limb feels cold, and the entire blood is dilated towards the central system, so that it could maintain the desired BP to sustain tissue and the life. Now the classification. What are the classifications of shock? So depending on various mechanism or various methods, you can classify. One is the initiating factor, the cause which leads to shock is one of the way you can classify. So it is classified as hypovolumic shock because there is decreased volume into the blood vessels. Second, cardiogenic shock, your heart is at problem, it is not able to pump the adequate amount of blood into your systemic circulation. Third is obstructive type of shock, when there is obstruction to the outflow of the blood from heart. The intravascular volume is good, heart is also good, but there is some obstruction to the outflow of the blood, which leads to shock, is called as obstructive shock. And finally, distributive shock is when you have some problem in the distribution. The blood is not adequately distributed, so the patient is having a shock picture. Next type of classification is based on the severity. How severe is the shock? So it can be classified as compensated shock, decompensated, and exsanguinating shock. So what is compensated shock? Compensated shock is a type of mild shock in which your body is able to cope up the necessary changes or decrease in BP by various mechanism it holds. So it can decrease the excessive urine output to prevent the water loss from the body. It will cause vasoconstriction of your skin and less important organ to maintain the intravascular volume, and it will cause sympathetic stimulation to more tighten the arteries so that the pressure in the arteries are maintained. So this is the compensated stage. In this patient will have slight tachycardia, the rate of the heart will increase to meet the necessary demand. Decompensated shock, body is not able to meet, you have to externally add some drugs, some what you call the crystalloids and colloids, so that to maintain the BP of the patient. And third is exsanguinating shock. This is irreversible changes have already occurred because of prolonged shock, and this patients have a high rate of mortality and morbidity. Third is consequences. If the patient is in shock it is the patient has developed a very severe form of shock and it is unresuscitable, you cannot, any amount of fluid and mechanism is not going to treat this patient, so it is unresuscitable shock. Or second thing is MODS. MODS is multi-organ dysfunction syndrome, when they have multiple organ dysfunction, as in your heart is failing, as your lung is failing, you have tachypnea, you have an anuria, and other changes, coagulopathy are there. So if any of these two are there, then it's called as a MODS. Next is you can classify shock on the basis of whether the peripheries of the person is hot, warm or cold. So if the peripheries of the persons are cold, it is because of the vasoconstriction, the shunt mechanism, and at times there may be a warm shock, as in the peripheries are not cold, it is called as warm shock. Of this classification, the most important and widely accepted classification is the initiating mechanism classification, that is hypovolemic, cardiogenic, obstructive and distributive shock. Now coming to what are the various types of shock. So hypovolemic, as I told you, it is a precardiac type of shock, as in blood has not reached the heart, but before that there is hypovolemia, that is decreased amount of preload um, into the heart, so that leads to the shock state. Second is cardiogenic. There is some problem in the heart, there is some pathology in the heart which leads to a shock condition. Third is obstructive shock. The heart is normal, your what you call preload is also normal, but the afterload, that is the your heart is not able to pump the blood outside. There is some form of obstruction to the outflow of the blood from the heart. So it is called as obstructive shock. And fourth is distributive shock. Distribution means there is some problem in the peripheries because of which there is unequal distribution of blood. Most of the blood is in the peripheries. There is less blood in the systemic circulation supplying the vital organ like heart and your kidneys and your brains. So patient, this is a relatively shock condition. And the lastly is poorly understood is an endocrine. It's a mixed type of shock. It's seen with hypothyroidism and other adrenal insufficiency. They have a mixed picture because of the excessive or decreased secretion of some hormones. Now, before moving the various types of shock, let us try to understand what is a blood pressure. Blood pressure, as you know, is the multiple of vascular resistance, the amount of resistance that is offered by the peripheral vessels or the arteries into the amount of blood cardiac output, the amount of cardiac output or the blood that is poured out of the heart. So, this two things determine the person's blood pressure. So, either there will be low cardiac output, that is, heart is not able to pump out much amount of blood, or second thing is your peripheral vascular resistance is decreased, so patient may have a decreased blood pressure, or it has increased because of some reason, so patient may have a higher BP. Cardiac output is the heart rate into the stroke volume. Stroke volume is basically the amount of blood pump in every beat or every heart, pumping heart. Stroke volume is the difference between the systolic and systolic volume and the end diastolic volume. So the amount of blood that is pumped in each stroke is the stroke volume. Stroke volume into the heart rate, in number of times the heart beats in a minute, is equal to the cardiac output. Mind it, this is very important that the vascular resistance and the cardiac output together forms the or maintains the BP. So accordingly, if the patient is having low cardiac output, the heart is at problem, then we'll have a state of shock. Or if the peripheral vascular resistance is very low, the blood is pulled in the peripheries, then it will also lead to a shock condition. So what are the conditions in which you have a low cardiac output? One is hypovolemic shock. There is not enough amount of blood is there into your preload or the veins, so that that amount does not reaches the your heart, and it is not able to pump or generate adequate cardiac output. Second is cardiogenic. Adequate amount of blood is there in the your vessels or the veins, but heart is not able to function properly, not able to contract, not able to pump the blood adequately into your arterial system. And third is heart is able to contract, but the problem is there is some outflow obstruction of the heart which leads to low cardiac output. So the cause of low vascular resistance is unequal distribution. Your peripheries have more of blood than your systemic vessels or the important organs. Now let us try to understand what are the pathophysiology of shock. So when is your BP low? So what happens? Your baroreceptors in the carotid artery senses the person's BP is low. So it sends signal to the brain that the BP is low. You need to do something for this low BP because it is not able to maintain the normal cellular respiration of the tissue and the important organ. So what does the brain do? Brain sends signal, sympathetic stimulation to the heart. So it will cause tachycardia. There will be increased heart rate. Second, it sends sympathetic stimulation to your skin or the shunt vessel, so that the shunt vessel dilates and it leads to diversion of blood from the skin toward the systemic circulation, so that patient starts having normal BP. Third, GIT is also not a very important organ, so it will shunt all the blood from the GIT towards the main systemic circulation so that it is able to maintain the BP in such patients. Next is it will stimulate the RAS, renin-angiotensin system, that is located in the kidney, so that the urine output of the kidney is decreased to its minimum and the blood and the intravascular volume is maintained. Next is lung also takes part in the maintenance of the intravascular volume. We'll discuss in later slide. So this is renin-angiotensin system. So what is renin-angiotensin system? When you have low BP or low intravascular volume, angiotensinogen that is secreted by your liver is acted upon by the kidney with the renin, and it is converted into angiotensin 1. This angiotensin 1 is further acted upon by the lung with an enzyme, ACE enzyme. Then it is converted to angiotensin 2. This angiotensin 2 causes vasoconstriction so that the BP of the patient or the blood pressure of the patient is increased. Second thing, it will stimulate the adrenal gland to release aldosterone. This aldosterone release will preserve or reabsorb the sodium chloride and the water into the intravascular volume and decrease the urine output in order to maintain a good BP, blood pressure. Now we'll deal shock one by one. One is hypovolumic shock. What is hypovolumic shock? Hypovolumic shock is in which there is decreased preload. That means your heart is not able to be filled with an adequate amount of blood. So if there is no adequate amount of blood, the heart is not going to pump adequate amount of cardiac output or a stroke volume. So what are the causes of hypovolemic shock? There can be two type of causes. One is because of hemorrhage. There is some hemorrhage, that is the blood loss. Either it can occur from the GI tract, GI bleed, uterine bleed, or some trauma. Patient has received some trauma, solid organ as in your liver laceration, your splenic laceration, renal laceration, or you have a omental bleed or a mesenteric bleed, or some long bones of the leg have what you call traumatized or fractured. That can also lead to bleeding. Second cause is because of volume loss, that is non-hemorrhagic type. When the patient is having multiple episodes of diarrhea, patient is having multiple episodes of vomiting, recurrent vomiting, burn patient, and third space loss, as in a patient having an acute pancreatitis, there is a lot of third space loss. This patient will have a volume loss. The blood is not lost per se, but there will be volume loss. Your water content of the blood is lost, so there will be a hypovolemic shock. Now the entire same mechanism is stimulated. Your heart BP is low, the baroreceptor is stimulated, stimulates the your brain to do something about it. So your shunt vessels will act, will have a cold clampy skin. Then we have a GIT, your secretions to the GIT will decrease, RAS angiotensin mechanism will be secreted, and your lung will also act in, and will be tachycardia. So this is the normal mechanism in most of the shock that will be stimulated. So there is severity. What is the severity of shock? How do you classify severity of shock? So there is three phases or three stages. So initially when the blood loss is less than 15% of the total blood loss, that is approximately 750 ml. The normal intravascular fluid is 5 liters. Your blood is 5 liters. So if there is around 750 ml of blood is lost, less than 750 ml is lost, your body compensates for that loss by various mechanisms. The most common mechanism is increases the heart rate. It tries to pump faster so that it can overcome the loss that has occurred less than, that is 15%. There will be slight lactic acidosis. We may have a slightly increased tachypnea, but that is can be managed. Second is decompensated. When the loss comes in between 15 to 30%, that is 750 ml to 1500 ml of the total intravascular volume, it is called as decompensated. Now the body is not able to compensate. It has to have some increase the the heart rate, and other mechanism is also stimulated in order to maintain. So This decompensated is classified into mild, moderate, and severe. Last is exsanguinating or unresusceptible shock. When the loss is more than 30 to 40% of the total volume, then the death becomes inevitable and it is irreparable. Mortality is very high. Lastly, what is MODS? As there is shock developing, patient may develop organ failure, as in lung, kidneys, heart. So that is called as MODS. When you have more than two organ failure system, then you call it as a MODS. Now, what are the various clinical features depending on the level of shock, whether the patient is in the compensated, decompensated phase? So, when you are compensated or the loss is less than 15%, patient may have a slight acidosis, lactic acidosis that body can manage. Kidney functions are normal, brain is normal, lungs are normal function. There may be slight increase in your pulse, BP remains normal, there is no problem. But when there is increase blood loss or the volume loss ranging from 15 to 20 35 30%, mild, moderate, severe, the acidosis goes on increasing, the kidneys from normal to become reduced to anuria, brain from mild anxiety to the comatose, lung function increased rate, what you call the respiratory rate to labored breathing, and finally the BP also start falling and it is not able to maintain the normal BP, that is 90 by 60, to maintain the normal cellular respiration. There is a classification of hemorrhagic shock if there is bleeding given by ETLS. So it classifies the shock into 1, 2, 3, 4 classes. So it is almost similar to the shock. So if the blood loss is less than 15 to 30%, 30 to 40 and more than 40. So they accordingly classify class 1, 2, 3, 4. So as the severity increases, there are changes. Pulse less than 100, more than 100, 120, 140. BP is normal and goes on decreasing. Respiratory rate goes on increasing up to 35, more than 35. Urine output, which is normal 30, more than 30, it goes on decreasing or becoming anuric. And the mental status also changes from anxious to confused to lethargic. Other symptoms or clinical signs, or you can see in the patient with shock, he or she will have a dry skin or mucous membrane. Skin turgor is decreased. Altered sensorium, patient will be confused, oliguria and tachypnea. Next is cardiogenic shock. So what is cardiogenic shock? Cardiogenic shock is decreased cardiac output or the stroke volume. The problem is in the heart per se. There is malfunctioning of the heart which leads to a decreased cardiac output. The heart is not able to pump blood outside the heart, and then there is hypotension. So what can be the cause? One is cardiomyopathy. If the patient has an MI, congestive cardiac failure, or rheumatic heart disease, then patient will have decreased cardiac output. Second is arrhythmias. There is some atrial fibrillation, ventricular tachycardia, ventricular fibrillation, etc., which is not generating adequate cardiac output and stroke volume. And third is valvular dysfunction. There is aortic regurgitation, mitral valve regurgitation, so that effective cardiac output is not generated, and patient may land up with what you call shock. Same similar mechanism is stimulated. Tachycardia is generated. Then the brain stimulates the skin and GIT and the kidneys and your lungs. Clinical features of this is, if the patient is having an MI or acute rheumatic heart disease, then he will present with a chest pain. If the patient is having cardiogenic shock, there will be a JVP that will be raised, and common features of shock as in seen in the other types of shock. The most important is patient will also have chest pain as there is some problem with the heart. Third type of shock is obstructive shock. Obstructive shock, that means there is some problem to the increase afterflow. That means there is some obstruction to the outflow of the blood from the heart. So either the problem will be in the right ventricle. So the blood that is coming outside the right ventricle and going into the lung or pulmonary artery, there is some obstruction in that area, or there may be a left ventricular outlet obstruction, as in in the aorta or somewhere in the aortic valve. So there is decreased diastolic filling. The heart is not able to fill properly, because filling is not there adequately. So what can be the pathophysiology? So mind it, there is obstruction to the outflow of the in the obstructive shock, and there is no pathology per se in the heart. Heart is totally normal, but the obstruction is outside the heart. The obstruction is in the some vessel or the veins or artery, that is, it has been drained. So it can be a right-sided heart outflow problem. That means the pulmonary artery that is at the problem. Our second thing is tension pneumothorax. Because of tension pneumothorax, the pleural cavity is filled with the what you call air, and this air leads to the collapse of the entire side of that side of the lung, and finally the pulmonary artery is also collapsed. So this leads to the pressure over the pulmonary artery. This leads to the outflow obstruction from the right side of the heart. Next is the obstruction can be on the left side also, like in causes are aortic stenosis. There is some problem of coarctation of aorta. This is one of the causes of obstructive shock. And finally, there can be a problem with cardiac tamponade. That is, there may be a traumatic pericardial effusion into the pericardial cavity. There may be a collection which is not able to not allowing the heart to pump the blood adequately into the artery. So it's a type of a obstructive shock. Clinical features almost same. If the patient is having a pulmonary embolism because of the DVT, patient will be having a chest pain along with the dyspnea. If he is having some problem in the heart, also developing a secondary heart failure, then he will have a chest pain. Patient may have a history of trauma. There can be pericardial effusion that has developed. DVT, patient may have a deep venous thrombosis in the leg, which has caused a embolus into the lung and causing a pulmonary embolism. Now the distributive shock. The other type of shock is distributive shock. Mind it, the cause of the distributive shock is in the peripheries, on the peripheral vessels. So in a normal shock, I told you the mechanism, all the peripheral vessels constrict to prevent or to minimize the blood supply to the your vein, your peripheral arteries or the skin. So you have cold clampy skin. But in this pathology, in this distributive shock, there is peripheral vasodilatation. So it is called as warm shock. The limbs of the patient will appear warm. So it's a warm shock. There is pooling of blood into the peripheral vessels or the arterioles of the skin. Why does this occur? Because of the decreased vascular resistance. Mind it, I have told you already, the BP is a multiple of your peripheral vascular resistance into the cardiac output. So if the cardiac output is normal but the peripheral vascular resistance is low, then also your BP or blood pressure will be low. So this is the cause of distributive shock. There is decreased systemic vascular resistance, and the cardiac output is normal or increased because it has to compensate for the decreased volume. So why there is distributive shock? There can be vasodilatation, peripheral vasodilatation, because of three conditions. One is sepsis. If there is sepsis patient, sepsis patient, there will be a release of nitrous oxide, which is a potent vasodilator, and there will be peripheral vasodilatation, and patient will land up in shock. Second is anaphylactic shock. Anaphylactic shock, because in anaphylaxis there is a release of histamine and leukotrienes, which leads to vasodilatation, and patient will have a peripheral vasodilatation and a state of shock. Third is neurogenic shock. There is a certain amount of sympathetic tone that is present normally in all vessels. So if this sympathetic tone in the peripheral vessels is lost, this will dilate and will lead to collection or pooling of blood into the peripheries, and the patient will develop a shock condition. What is septic shock? When you have infection or sepsis in your body that releases mostly by the gram-negative organism called as endotoxins. This endotoxin, nitrous oxide, the potent vasodilator, and patient will have a peripheral vasodilatation, and there will be a state of shock. Mind it, there is no decreased cardiac output. There is increased cardiac output because of the severe contraction of the heart. So there will be a hyperdynamic heart. There is decreased systemic vascular resistance. An important terminology is SIRS. It is the body's response to any insult that has been occurring to the body, or either in a form of trauma if you have a trauma, or in a form of infection to the tissue. So when there is infection or trauma that is received by the body will respond in certain way. Trauma, as in we are doing a surgery, you give an incision, even that is a trauma or insult to the body, or he has received some trauma. So this will, your body will respond to this trauma in certain mechanism that is called as systemic inflammatory response syndrome. SIRS was given in 2001. It has four basic criteria. If more than two are met, then you call it as a SIRS. So what are those criteria? One is increased TLC count. Your WBC count is less than 4,000 or more than 12,000. Increased temperature less than 36 or more than 38. Increase heart rate that is more than 90 per minute, and increase respiratory rate that is more than 20. So any of this, if two are met, two are there, two plus is there, then it is called as an patient is having an SIRS. Simple way to remember this is remember increased TLC. So increased TLC means the TLC has increased, it is less than 4,000 or more than 12,000. T is for temperature, there is elevated temperature, patient may have a less than 36 or more than 38. L for lung function, that is patient will have a tachypnea rate more than 20. And lastly C is cardiac, that is heart rate is more than 90. So this is a simple way to remember. Now what is sepsis? Sepsis is SIRS plus there is some identifiable source of infection in the body. So patient says I am having a cough, that means with productive cough, that says the patient is having a pneumonia. If patient says I am having an abscess in my hand, that suggests that is a source of infection which has leads to SIRS. So it's a sepsis. If this sepsis is very severe, the source of infection is there, and he develops an organ dysfunction, then you call it as a severe sepsis. And lastly, septic shock. What is septic shock? Septic shock is a state of severe sepsis that is not responding to normal conventional IV fluids and requires some vasopressors and inotropic drugs to maintain the BP. Then such patients are called as having a septic shock. But there is a problem with SIRS. So what is SIRS? The problem with SIRS, need some local source of infection as to label it as a sepsis. So if you cannot find, or if there is no source of infection, then you cannot label it as a sepsis. You will call it as an SIRS. Second thing, there are various treatment guidelines for various pathologies. Whether if the patient is in simple SIRS, if the patient is having sepsis, if the patient is having septic shock. So there are different guidelines. So so there is less aggressive treatment for sepsis, whereas septic shock there is more aggressive treatment. Third is the rate of mortality turned out to be higher in a case of sepsis in which you give less aggressive treatment. So it was seen the rate of mortality was higher. And next is non-infectious processes also lead to similar physiological changes as in infectious process, as in example pancreatitis. Mostly pancreatitis is non-infectious, it is just an inflammation, not an infection, but still it has a high rate of what you call mortality, because we treat it as a what you call a SIRS, but it is way more than SIRS. And if you do not treat it like a septic shock condition, then the mortality is very high. So what is the answer for SIRS? These drawbacks and these disadvantages of SIRS is they have come up with a new terminology, that is SOFA score in 2016. So what is SOFA? SOFA is sequential organ failure assessment. You sequentially assess the organ whether the patient is developing an organ failure or not. So it is called a SOFA score. It gives you a neat definition of sepsis. So if there is baseline increase of 2 points in the SOFA score, you label it as a sepsis without any source of infection. There are six criteria with 5.8. So the total score turns out to be 30. So one is of CNS, one is of CVS, RS, hepatobiliary, renal, and coagulation. So advantage of this scoring system is basically the non-infectious processes like pancreatitis are also taken under consideration, and also managed properly. Disadvantage is it's a very laborious or a very tedious job, and it will need some lab investigation before confirming what is the score, and it delays the treatment at times. So this is SOFA score. It has respiratory, coagulation, liver, cardiovascular, CNS, and renal parameters. So the respiratory scores from 0 to 4, that is 5 score, more than 400, PO2 FiO2 ratio. Then you have platelet more than 1.5 lakh, less than 1.5, less than 1 lakh, 50,000, and less than 20,000. Then you have a bilirubin of the patient less than 1.2, 1.2 to 1.9, 2 to 2.5.9, and 6 to 12 approximately, and more than 12. Cardiovascular mean vascular volume more than 70, mean arterial pressure more than 70, mean arterial pressure less than 70. Patient needing inotropic support to maintain this MAP less than 5 ml. If he needs epinephrine, non-epinephrine, accordingly they have classified it into further scoring system. CNS may, if you have a perfect score of 15, 13 to 14, and then finally less than 6. Creatinine also less than 1.5, and further it is increasing more than 5. So to overcome the problem of the SOFA score, they have devised something called as Q-SOFA. Q-SOFA is quick and bedside assessment of the patient. They have narrowed down the score is three things: brain status, BP status, and the breathing rate. So BBB, that is brain status, blood pressure, and the breathing. Brain status, as in if the patient developed an altered mental status, confusion, drowsy, or lethargic, or the stupor. Second is your blood pressure, if the blood pressure is less than 100 or more than 100. And third is you have the respiratory rate, your breathing rate, that is if it is more than 22, that suggests patient is developing a chances of any of the two score is there, then the patient will develop a sepsis in the near future. What is the mechanism of septic shock in this patient? So what happens is, because of the microbial product that is released into the bloodstream, they have various mechanisms. This endotoxins, they are a procoagulant in nature and antifibrinolytic. So there will be microvascular thrombosis of the vessels in the body. Next is there are some potent vasodilators and increased permeability mediators, that is IL-6, IL-8, and nitrous oxide and others, that will lead to increased permeability and lead to what you call multi-organ failure. Third is there are some drugs that will cause anti-inflammatory or immunosuppression uh, of the immunity of the immune system of the patient. So this all coupled up to make to cause the multiple organ failure. Clinical feature with patient having a septic shock is high fever, warm extremities, the warm extremity which is normally cold in a shock, but in the case of septic shock it will be warm. Features of shock will be always there: low BP, oliguria, tachypnea, and altered mental sensorium. Now coming to anaphylactic shock, it is almost similar to septic shock. Only thing that differs is patient will give history of, or he has developed a reaction to some drug or a food material. There will be additionally rashes over the body, and the features of shock will be neurogenic shock. So in neurogenic shock, there is transaction of the spinal cord, either mechanically, that means because of some trauma, or there is some infection, that is acute transverse myelitis because of infection of the spinal cord. This leads to the loss of the sympathetic tone that is exerted by the cord over the blood vessel and the heart, and the vessels dilate, and this leads to pooling of blood and causing a distributive type of shock in the patient. Clinical features: if the patient has received a trauma, patient will have a history of trauma, and if there is some infection, patient will have fever, and post infection patient will start having limb paralysis, I mean lower limb paralysis, or paraparesis, or your quadriparesis. Endocrine shock. Shock is type of a mixed shock. There is a combination of a hypovolemic type of shock features, cardiogenic and distributive shock. It is seen in patients having an hypothyroidism or hyperthyroidism, and in patients with adrenal insufficiency like an what you call Addison's disease. Endocrine shock. Now coming to the investigations. What are the investigations would you like to do for a patient in shock? So, if you're suspecting a cause as a heart cardiogenic problem, patient is having cardiogenic problem as in a MI, or there is valvular dysfunction or arrhythmia, you get an ECG, you get a 2D echo, and you measure the central venous pressure of the patient. If you think there may be a what you call tension pneumothorax, there may be a pulmonary embolism or some other problem, then you can get a chest X-ray, and a pulmonary artery capillary wedge pressure can be measured. If there is some problem of sepsis or infection, you get a CBC and the procalcitonin level of the patient, that will tell you whether the patient is in septic shock or not. If there is suspecting a bleeding, CBC will help you, or HB will tell you how what amount of blood patient is having. And in case of infection, blood culture, urine culture, WBC count, and procalcitonin level of the patient will also guide you to differentiate you between septic shock and other causes of shock. So these are the batteries of investigation which we do normally. If you're suspecting a arrhythmias or an MI or a valvular dysfunction, you get an ECG and a 2D echo. If suspecting a lung problem, that is pneumothorax or the pulmonary embolism, so you get a chest X-ray and measure the CVP of the patient. If they're suspecting a pulmonary embolism, you get a pulmonary artery wedge pressure. Agar there is some problem in the blood, that is hypovolemia or a bleeding, you get a C for the CVP of the patient will tell there is low CVP, and there will be hemogram, there will be decreased HB of the patient. Infection, you go to hemogram, look for a WBC, and look for a blood culture and lactic acid levels. Now coming to the treatment, what are the various treatment for various types of shock? So there are four types of shock: hypovolemic, cardiogenic, distributive shock, and obstructive shock. So when you are having a patient of hypovolemic shock, you have diagnosed the patient is having hypovolemic shock, that can be corrected by IV fluids, either crystalloids or colloids. And if there is this hypovolemic shock is because of blood loss, so the best product or the best fluid to resuscitation is always the blood if the patient is in shock. So this is the treatment for a hypovolemic shock. Either you give IVF, IV fluids in a form of crystalloid or colloid, and if there is a bleeding, so the hypovolemic shock is because of bleeding, you can initially resuscitate the patient with crystalloid and colloid, but the best fluid is always the blood in a case of hemorrhagic shock. Next is cardiogenic shock. So the cardiac is not able to pump adequate amount of blood. So if it is because of the less cardiac output because of the non-contractility, you can give an endotrope. If there is some arrhythmias, so you can do a cardioversion, you give an shock. And if there is valvular dysfunction, you do a valvuloplasty or a valvulotomy. If there is stenosis of the valve, that is aortic stenosis, aortic valve stenosis, then you can do a valvulotomy. Or if there is metal valve stenosis, you can do a metal valvulotomy. If the shock is because of the distributive type of shock, that means it may be a septic shock. We have to give an antibiotic to the patient to cover the gram negative and the higher bacteria. The BP is low, you have to give an inotropic support to the patient and vasopressors, and adequate amount of IVF is also needed to compensate for the fluid loss that has occurred because of the septic foci. Lastly, if there is an obstructive type of shock, patient is having a pneumothorax, you can do an immediate emergency needle thoracocentesis and followed by a ICD insertion. If there is pulmonary embolism, you can try thrombolysis by giving some thrombolytic agents. And if there is stenosis of the what you call aorta, aortic valve stenosis or coarctation of aorta, you can manage it by stenting of the aorta. So thank you. Hope you could understand some important basics of the shock. Thank you very much.